recording. Right. We are very excited to continue our Lunchtime Learning series with a special presentation on Polymyalgia Rheumatica and giant cell arteritis by Dr. Aditya Pawaskar of UHS Rheumatology in Vestal. Dr. Pawaskar completed his initial medical training at Lokmanya Tilak Municipal Medical College in Mumbai, one of the most respected medical colleges and research institutes in India. He completed his residency and internship at Westchester County Medical Center and then went on to a fellowship at the University of Connecticut. He is board certified by both the American Board of Internal Medicine and the American Board of Rheumatology. When we began discussing this series, we asked each of our medical providers to choose the topic on which they'd like to present. As a result, our topics include many of the most common rheumatic conditions seen at UHS Rheumatology. But Dr. Pawaskar took a different approach. PMR and GCA don't have the name recognition of, say, lupus or rheumatoid arthritis, and that's precisely why he chose to focus on them today, to raise awareness. While both are fairly common in our region, he told me they are not always well recognized or treated effectively, which can lead to unnecessary suffering for patients. And it was a desire to reduce suffering, as well as the satisfaction of reaching a correct diagnosis and treatment plan that led him to a career in medicine and ultimately to specialize in rheumatology. No 2 days are the same in rheumatology, he told me, and that variety is something that he really enjoys. Along with explaining complex medical concepts and problems in a simple way so that his patients understand what's going on and how they can best improve their health and well-being going forward. He'll be doing the same for us today. We know that these twin topics are of personal interest to many of you. Whether you're here with us today because PMR and or GCA touches your life in some way or to increase your professional knowledge, welcome. We invite you to ask questions, and if you feel comfortable, please feel free to share your personal experience with us. We would love to hear your stories. You can do so at any time in the presentation via the chat or by raising your hand, and we'll also allow time at the end for questions and comments. Dr. Pawaskar, without further ado, I'll turn it over to you.
All right, good afternoon. Welcome everyone. My name is Dr. Aditya Pawaskar and I'm a rheumatologist here at UHS Rheumatology in Vestal. It's so good to have all of you here today. And it's my pleasure and my privilege to be able to talk to you about a condition that is not uncommon, but unfortunately is not as well recognized. And hence I believe that there needs to be more awareness about this so it's better recognized and better treated so patients suffer less. So I'm going to try to keep this talk relatively informal and casual. So at any point, if there's questions, please feel free to interrupt, raise your hand or ask questions. And I'm sure one of our moderators will, convey whatever your questions are to me and the group at large. And I'll try to keep it simple and I try to break down these somewhat complex, autoimmune or inflammatory diseases to something that can be understood by everybody, even if you don't have a medical background. But still, if something's not clear, please feel free to ask for clarification. So to move on to the topic today, we're going to talk about something called as Polymyalgia Rheumatica, or PMR in short, or as it's known colloquially. We do see a lot of PMR here at UHS Rheumatology. And as you can see on the slide, that's where we are based at UHS Vestal, just off the Parkway. And we do serve the greater Binghamton and the surrounding areas and counties. So we do get a lot of referrals from surrounding clinics and primary care and other hospitals as well. So that's essentially our catchment area. And our goal is to provide comprehensive rheumatology care and diagnosis and management for these patients. So if Melissa, you can go on to the next slide. All right, so first off, what is polymyalgia rheumatica? So polymyalgia rheumatica is an inflammatory condition of the joints and some of the surrounding structures around the joints. It is not technically an autoimmune disease in the sense that there are no antibodies, and I'll talk about this clarification a little bit later, but it is certainly an inflammatory condition. So there is a lot of inflammation in and around the joints. It is actually a fairly common condition. It is not uncommon. I do see a lot of this over here. Already over the last few months, I think I've had at least about 15 to 20 patients whom I've either had polymyalgia rheumatica or I've given them a diagnosis of polymyalgia rheumatica. But unfortunately, it's not as well recognized, and hence sometimes these patients continue to suffer without getting the appropriate diagnosis and treatment. Now, one thing to know about polymyalgia rheumatica is that it is a condition typically seen in elderly people. And the usual demographic is people above the age of 50. You will not see this condition in younger people in their 20s or 30s. So if they have symptoms similar to this, it's not polymyalgia rheumatica, it is something else, and you must continue your investigation. But this is a condition seen in people over the age of 50. And what are the predominant symptoms? What do these people have? Well, they have this widespread aching or joint pains or aches and stiffness, which is predominantly in the shoulders and in the upper arms, the neck, and then they can also have it in the lower back and in the thighs and the hips. So if you look at the picture, those red areas which have been highlighted, those are predominantly where these patients have their symptoms. They can have symptoms more distally in their hands and feet too, but this is where the symptoms predominantly are. These symptoms are usually worse in the morning. So usually these patients will say that, okay, yeah, my mornings are awful, or mornings are horrible. I just have trouble, getting out of bed. I feel extremely stiff in the morning. So that's what you want to look out for. Now, one thing is even regular old arthritis or osteoarthritis, the commonest form of arthritis most people get with age, also can give symptoms in these similar joints and also can present with stiffness in the morning. However, the stiffness doesn't usually last as long with osteoarthritis. With polymyalgia, the stiffness is usually prolonged. They'll have stiffness for a couple of hours or even longer than that, and sometimes stiffness lasting almost all day long. So that's polymyalgia rheumatica. Now, before we move on ahead, I do want to clarify one thing. A lot of you may have heard about a condition called fibromyalgia. I know it sounds similar, but these two are completely different conditions. Fibromyalgia is more of a relatively neurologic condition. There is no inflammation in fibromyalgia. They both do have some overlap when it comes to their symptoms, but they are two very different conditions and treated very differently. Just a couple of days ago, I had a patient who thought he had fibromyalgia, but actually had polymyalgia. So it's important to get that clarification right. So if we can move on to the next slide, please. Okay. So the question, why does PMR happen? Like, why do people get PMR in the first place? Well, we don't exactly know, unfortunately. There has been some research in this area, but we don't exactly know which genetic mutation or what triggers this sort of thing. What we do know is that this pain from PMR may be related to inflammation of something called as bursae, which are basically the sacs of fluid around the joints near the shoulders and the hips. There is a genetic predisposition to this, but there is no one specific genetic mutation that has been identified. And there are certain potential triggers. It might be stress, it might be viral infections, but these are not well described. And in most cases, we can't usually identify a specific trigger. What we do know is this is not caused by medications. Medications don't cause this. In general, if you want to talk about demographics, like who gets this? So both men and women can get this, but it is slightly more common in women as compared to men. And if you want to talk about demographics more, it's usually a lot more common in people of Caucasian origin, especially people from sort of Northern European heritage. But it can certainly happen in other people too. I have certainly seen some Hispanic and some African-American patients of mine who also have PMR, but it's a lot more common in people of Caucasian origin. Also, one other thing that there is another related autoimmune disease called giant cell arteritis or GCA, which some people with PMR can also get. These are sort of sister diseases. I will talk more about giant cell arteritis on a later slide. The good news about PMR is it responds very quickly to treatment. So while we can't necessarily prevent PMR from happening, we can certainly treat it very effectively. So that's something to keep at your bottom of your mind. So if you can move on to the next slide. Okay, so what are the symptoms of PMR, both as a patient or as a relative of a patient or as a healthcare provider? What are the sort of things you want to look out for? So the predominant symptoms are these widespread aches and stiffness. It will not be in just one part of the body or in one side of the body. These are usually more widespread and predominantly in the shoulders and the hip girdles, and it can radiate to the neck, it can radiate a little bit to the chest, and it can radiate to the hips or a little bit to the thighs. But essentially, most of the symptoms are in the shoulders and in the hips. Typically, the symptoms come on quickly. They'll say, oh, I was doing fine a few days ago, and then this started suddenly. And a lot of people will say, oh, it started overnight. I was doing fine yesterday, and I woke up in the morning, and suddenly I was extremely stiff. But if they have not been diagnosed, when they started getting their symptoms, they can have chronic symptoms. So most patients will have acute symptoms, but some will have chronic symptoms if they've had it for a while. As I mentioned, it's on both sides. It's certainly not related only to one side. If it's only on one side, you're probably looking at something else. People will also complain that my shoulders are so stiff. I have trouble raising my arms above my shoulders. So they'll be able to do this, but they won't be able to go above their shoulders. Some of them can have achy hands and wrists as well, but that's not as common. And other symptoms you want to look out for, especially you want to sort of elicit this diagnosis for a healthcare provider, is they'll typically say that the more inactive I am, the more stiff I feel. When I move about, I feel a little bit better, but especially when I'm inactive, if I've been sitting for a while, I feel more stiff. They will have trouble sleeping because of this pain. So this pain will hurt them at night as well. They'll have trouble doing their regular activities. They'll have trouble putting on their clothes, getting dressed, bending down to put on socks will be painful. And typically they'll complain that, okay, getting in and out of a car. So especially if you have a car that's a little low, sort of getting in the car or getting out of a car is very painful, or even sitting up and down can be painful. Some of them can have a mild fever, but that's not a common manifestation. So next slide. Now, I mentioned before, there is another condition called giant cell arteritis, or GCA. Now, this is sort of like another inflammatory condition in the same spectrum or same realm as PMR. So with PMR, you have inflammation in and around your shoulders and hips. Whereas with GCA, you actually have inflammation in some of the big arteries that start from your heart and basically go up to your head and your brain. So GCA is a type of what we call as vasculitis, or basically inflammation of your blood vessels. Now, what are the symptoms of this GCA? Well, the commonest symptom is these people get sudden headaches on the sides of their head, so over the temples over here. And this happens because something called as the temporal artery, which you can see in the picture on the left, is typically inflamed. And that's why this disease is also sometimes called as temporal arteritis. The other symptoms these people can get is they can get scalp pain. Their scalp will be very tender. So whenever sort of they comb their hair or they brush their hair, it will be very painful. The other thing that can happen, and that's something that's very dangerous and we got to look out for, is they can get involvement of the arteries that actually supply their eyes. So if those arteries are involved, they can get blurry vision, or they can get double vision, which is typically sudden onset. And the big thing to note for, especially for healthcare providers, is that if this is left untreated, they can lead to vision loss, which can sometimes be permanent. So in such cases, an immediate diagnosis and immediate treatment is extremely, extremely important to prevent any further visual loss. However, it's not just those two arteries. Any arteries that basically go up from the heart, in the neck, in the jaw, all of these arteries can get affected, and even some arteries that go up to your upper extremities. So these people can also typically complain of pain in their jaws, especially when they move their jaw up or down. So typically when they're eating, when they're chewing food, they'll complain of, oh, my jaws hurt specifically when I'm doing that, but not at rest. They can also get pain at the front of their neck. They can get chest pain. They can get pain in their arms. And because there is significant inflammation, these people can also get some what we call as constitutional symptoms. So these people can get some fevers, they can sweat, they can get weight loss as well. So who gets this GCA? Well, it's difficult to say for certain. So some people who have PMR can eventually also develop GCA. Some people will initially get GCA and then sometimes get PMR. And some people can have just one of these diseases without ever getting the other. So it's difficult to say for sure, but certainly if you get one, you are at risk of getting the other. So both the patient and the healthcare provider should be aware of this, and the patient should be told about these symptoms. And, that's what the patient should be instructed to look out for. And if these are present, your patient should get in contact with you immediately. Next slide. So, okay, so let's say we clinically suspect PMR. So how do we go about making a diagnosis? So typically, what will a rheumatologist do? So the most important thing is a good history. We want to know in detail about your symptoms. We want to know exactly what's going on. We want to know how it started, how it progressed, how long it's going on for. The other thing is we'll typically do a thorough physical exam. So we'll examine your joints, especially your shoulders and hips, and we'll see if there is any signs of inflammation, if there is any sort of stiffness, if there's decreasing range of motion, if there's any tenderness. And for the GCA, we will basically examine the arteries that go up, from your heart to your head. And we'll notice if there's any abnormalities in those arteries. Is there any pain? Is there any tenderness? That sort of thing. If there's suspicion for GCA, we will also usually refer to an ophthalmologist to make sure to get your eyes checked to see if there is any inflammation over there. Now, to look for inflammation, there are typically two tests which are called as markers of inflammation or inflammatory markers. These are something called as erythrocyte sedimentation rate, or colloquially known as SED rate or ESR. And there's another one called as C-reactive protein or CRP. These are basically markers in your blood. So these are blood tests that we can do. And typically with PMR and GCA, these are significantly elevated in the blood. And that can certainly be very helpful to make a diagnosis. However, one very important thing to note, especially for healthcare providers, is about 10 to 15% of patients with PMR or GCA will not have elevation of these markers. So they can have normal markers, but clinically still present and act and look very much like PMR or GCA. So just not having these high markers does not mean you can rule the disease out. If you still clinically suspect it, you should still refer to a rheumatologist and you should still consider treating for it. And I've certainly seen these patients. So that's a pitfall, or that's a mistake some clinicians can make, that, okay, the inflammation markers are not high, so maybe it is not PMR, and then you can miss the diagnosis. The other thing to note is these markers are non-specific. Any inflammation can make these numbers go up, or any infection or cancers or the other things can also cause these inflammation numbers to go up. So these are not specific to PMR or GCA. That's another thing to keep in mind. Typically, a rheumatologist will also do other blood tests to rule out other autoimmune disease like rheumatoid arthritis, which can also sometimes present with similar joint pain and joint inflammation and swelling and that sort of thing. The other thing that we sometimes do is we do imaging. So we can do MRIs of the shoulders or hips to look for inflammation. And especially when it comes to GCA, sometimes what we do is we do a biopsy of the artery that is at the side of your temple here, called the temporal artery. So we send you to the surgeon and we take a small biopsy and we actually look if is there any inflammation there that is suggestive of GCA. And that can help us make a diagnosis, as you can see in the picture over here. So typically that's how we diagnose PMR, but these tests are supportive. The main diagnosis is still clinical. So a history and physical should not be missed. Next slide. Okay, so let's say you make a diagnosis. So how do we treat PMR or GCA? So the medication of choice and the best medication that works well for PMR and GCA is steroids. So we typically use prednisone. Now for PMR, you don't need high doses of prednisone. You can get away with low to moderate dose. So typically most patients will respond to 10 to 15 milligrams of prednisone every day. And the one other thing that prednisone will immediately make these patients feel better. And that's actually an important diagnostic clue. Let's say if your patient does not feel better after being on prednisone for a week or so, it's probably not PMR. And then you got to investigate, okay, why is this patient not getting better? What else could this be? What's going on? And the good thing is people with PMR, once they are on prednisone, feel dramatically better and they can basically get back to their normal lifestyle very quickly. And which is why starting treatment soon is extremely important. Usually for GCA or giant cell arteritis, it requires higher doses of prednisone because there is much more intense inflammation. So with that, you typically do high doses of steroids and then eventually we lower them. Now, typically once I start a patient on prednisone for PMR and he feels better, the next obvious question is, okay, doc, what's next? How long am I supposed to be on prednisone? Now that I feel better, do I stop it? And the answer to that is unfortunately not immediately. If you suddenly stop the prednisone, PMR tends to sort of flare back up. So we usually don't suddenly stop the prednisone. What we do is we slowly taper off the prednisone over the next few months. And there's two reasons for that. One is so that we make sure the PMR does not flare back up. And the other reason is you can be dependent on prednisone once you've been on it for a while. So suddenly stopping it can give you other problems because you're dependent on it. So that's why we always taper steroids. We don't suddenly stop it. There are some people who might even need longer treatment with steroids. They sometimes you need to treat them for even a year or a couple of years or so. And the other thing with PMR is typically most patients will feel better and we're able to back off the steroids, but some of these patients can again get symptoms of PMR over the next few weeks or months or years at some point. There's no way to predict it. But if that happens, thankfully, we can just treat them the same way we treated them the first time and they do feel better. Now, one important thing to note, so prednisone is an anti-inflammatory, all steroids are. But other NSAIDs, your over-the-counter anti-inflammatories like ibuprofen or naproxen, they don't work for PMR or GCA, even though they're anti-inflammatories. So that's not what you want to be using to treat PMR. These patients will not respond and they won't feel better and their disease will remain uncontrolled. Now, there are some patients who, once they are on prednisone, they feel well, but once we start backing off the prednisone, their symptoms come back. So they always need some steroid on board to sort of keep their symptoms under control. In that case, we always worry about what are the long-term side effects of this prednisone, and I'll certainly discuss that on the next slide. But are there other treatment options for this? And there certainly are. The two commonest medications used are something called as methotrexate, and then there's another injectable called tocilizumab. Now, these are also medications that help suppress a part of your immune system, and these are basically alternatives to steroids. We typically don't start them right away because they take a little bit time to act, whereas prednisone acts very quickly, but these are options for long-term treatment if they become dependent on steroids and if we want to wean them off of the steroids. And regular follow-up with a rheumatologist is very important because this is a disease that can flare back up. So you need to make sure that you are treating it well, you're keeping it quiet and under control, and you want to make sure there's no side effects from the steroids, that we are giving to treat this. So if we can move on to the next slide. So what are the side effects of steroids? So steroids are basically hormones and they can have many side effects. They're very potent medication. There is a laundry list of side effects, but the most important ones are they can make your blood pressure go up, so they can worsen hypertension. They can cause you to gain weight. They can make your bones brittle and cause you to get osteoporosis and increase your risk of fractures. They can affect your mood. Some people feel irritable while on steroids, and they can certainly cause you to feel sleepless at night, which is why we typically give them first thing in the morning. They can certainly either cause you to develop diabetes or make existing diabetes worse. And they can also cause cataracts or glaucoma if you take them for long. They do also increase your risk of infections because they suppress your immune system. The side effects are related to two things, depending on how high a dose you are on and how long you take the steroids for. These are the biggest things to be concerned about. Now, most people with PMR are not on high doses of steroids, but they certainly are on steroids for a long time, at least a few months or sometimes even longer. So overall, that's why we try to taper the dose of steroids as soon as we can to overall decrease their cumulative exposure to steroids. And if they still need steroids, that's when we consider these alternative immunosuppressive medications, the methotrexate and the tocilizumab that I mentioned earlier, to overall decrease their long-term risk of side effects when it comes to prednisone. Next slide. So that was a basic primer about PMR and giant cell arteritis. There is obviously a lot more to it that I didn't get into all the nitty-gritties, but if you're interested in learning more, so the American College of Rheumatology has an excellent patient fact sheet, and that's available at the link in the presentation. And this presentation will be available later. So you can always, either do a Google search or, get it from the presentation. And that is excellent information, and information you can trust about what PMR is and what sort of other resources are there to help with this sort of thing and what other things you can do. Another great website is simpletasks.org. It's a public awareness campaign, again, from the American College of Rheumatology, which has some great information and it put in a very simple way, which can help you understand this disease, especially, if you go home and you have some more questions or like you want to just understand this disease better, that's a great link. And also the official website of the American College of Rheumatology, rheumatology.org, has some great patient models, not just about PMR, but about a bunch of autoimmune diseases. And that's information you can trust, and it's all verified stuff. So what you are getting is accurate and not wrong or fake or anything like that. With that, that's the end of my presentation, and I'll be happy to take any questions and answer any doubts that you might have. And before I do that, thank you for attending. It was a pleasure to meet you all and talk with all of you today about two diseases that I feel are relatively underdiagnosed and not very well known. And that's our team at UHS West Hill. So Dr. Bhavali, Dr. Ludo, myself, and all our wonderful nurse practitioners. And we are here to help you deal with all sorts of rheumatology issues. So anytime you have any questions, feel free to reach out, and thank you.
Dr. Pawaskar, thank you so much for this very informative presentation. Audience, if you'd like to ask a question, please feel free to unmute, or you can use the chat. We do have a question in the chat. Are the same age parameters included for arteritis?
Yes, that's a good question. Yes, exactly. It's the same age parameters for both the Polymyalgia Rheumatica or PMR and the giant cell arteritis or GCA. These are typically diseases seen above the age of 50. Now, the 50 is a relatively arbitrary parameter. So it's not like if you're 49 years old, you absolutely can't get it. But typically, we do not see these diseases in people in their early 40s or any age younger than that. So it is the same age parameters as the PMR.
Okay. How long does it last is another question posed in the chat.
So how long does it last? So if untreated, yes, it can last for weeks or months or even years. I unfortunately have seen some patients who had it for months and it just was missed or, not really diagnosed, or diagnosed but not appropriately treated. A lot of, other providers can sometimes make the mistake of treating it with steroids for about a week or so, and the patients do feel better, but then they stop the steroids and the symptoms just come right back up and they're back to square one where they began. So this is the sort of thing that you need to treat it for longer to keep it under control. And some clinicians, especially if they're not rheumatologists, may not be very comfortable prescribing steroids for long term, especially given all the side effects. So that's when you need to come see a rheumatologist, where we can sort of take over, make sure you're treated right, and then over time, make sure you're on the right sort of medications which don't give you a lot of side effects. Now, to talk about like how long it lasts, typically, once we start treating it, it should get better immediately within a few days for PMR. And even the giant cell arteritis, within a few weeks, the symptoms do go away. After that, patients can fall into one of three categories. Some patients who, in one way I say are the lucky ones, are able to eventually completely come off of the steroids without, the symptoms coming back, and the symptoms never come back in the future. So they just get it once and they don't get it. Some other patients similarly are able to come off of the steroids, but after they're completely off of their treatment, at some point in the future, few weeks, months, years, it can come back. But yes, we then treat it the same way and it does respond to treatment. And the third category of the patient are relatively unlucky ones, in the sense that once we are backing off the steroids, they immediately get symptoms back. And that's typically when we need to use these other medications to treat it more long-term.
Dr. Pawaskar, if there's a couple more questions in the chat,
yes.
Do these conditions run in families?
So yes, there is some genetic risk to this, but it's not like a one-to-one risk. So it's not like, oh, if you have it, there's a 50% or 25% chance your kids get it. It's not like that, because the genetic risk is sort of multifactorial. So there's a bunch of sort of things that have to kind of fall in place for you to be genetically predisposed to getting this. So yes, there is some degree of genetic risk, but it's not that it typically runs in families. So most people who have PMR don't really have a family history of it, but some might have it.
Okay. And then how long do you typically see your patients are on, all right, I'm not going to even try to pronounce it, after they have tapered off of steroids?
So that's a good question. So the goal of tocilizumab, the primary goal is to, number one, is to try to take him off of the steroids. Now, tocilizumab also does have some side effects of its own, but relatively the side effects are much lesser as compared to steroids. So when I put somebody on tocilizumab, my first goal is to keep them on tocilizumab and see if I can get them off of steroids completely. Once that's done, I want to make sure that the disease is in remission or basically under control on tocilizumab alone. Now, once that is done, typically in a few months or even after about a year of treatment is when, if everything is quiet, we can start thinking about either backing off the tocilizumab, making it less frequent, or decreasing the dose, and eventually even stopping it altogether. With the understanding that, yes, there is some risk that this might recur if you're off of therapy. So at that point, it becomes a conversation about risk of ongoing therapy versus risk of the disease coming back potentially sometime in the future, which it doesn't happen in everybody. So it's a very individualized decision. The goal is to not keep patients on these treatments all their life, but we typically do keep them on it for a few months at least to make sure things are under control. And then if everything is quiet, they're feeling well, that's when we have the conversation about starting to back off and seeing how things progress. And then we keep an eye on the inflammation numbers, make sure they don't go up. Typically, once you start treatment, the inflammation numbers will normalize. They'll come down to normal again. And then we check those every once in a while to make sure they're not going up. But again, to specifically answer the question, there is no specific time period that, we stop it after 6 months or anything. It's a very individualized thing, depending on what your symptoms are, what your disease exactly was, how you're doing, and it's based on that.
Okay, and I did receive a message from one of the participants saying that there is a Facebook page for PMR. That's very informative if anybody is looking to find community on this topic. Any other questions? These have been great. Oh, all right, well, it sounded like someone unmuted. No? All right, well, Dr. Pawaskar, thank you so much again to you and your colleagues at UHS Rheumatology and to each of you for joining us today. We hope you'll join us for the next installment of this series, which will be on Tuesday, July 6th. Our topic will be gout and pseudo-gout, and Dr. Rachel Ludo will present. She's actually on today as well. Thank you again for joining us today, and we hope to see you again soon.
Thank you so much for attending. It was a pleasure to talk with you all. And if there's still any questions, any clarifications, anything like that, don't hesitate to reach out to me. I'd be more than happy to discuss and help out.
Wonderful. We'll share these slides as well as a recording from today's presentation with everyone that presented. Thank you and have a wonderful day.